All right, let's dive in. Today, we are decoding a really crucial story that's happening inside your body, and it's a story written in lab results. We're going to break down the tests that measure how your blood clots and see how medications can completely change that story. Just think about it for a second. Your blood has two jobs that are total opposites. It's got to flow smoothly through miles and miles of blood vessels, but the second there's a leak, it needs to plug it up, like instantly. It is an incredible balancing act, and today we're going to look at exactly how we measure it. The official name for this whole process is coagulation, and it's not just one thing that happens, nope, it's a cascade, this precise, beautifully timed sequence of events. Kind of like a line of dominoes falling, all leading to one single goal, making a good, stable clot. So to make this whole cascade thing way easier to picture, let's use a little analogy. Imagine the process of forming a clot is like a road trip to one specific destination. There are two different highways you can take to get there, but they both eventually merge into one final road. Okay, so let's look at this highway map. You've got the extrinsic pathway, that's one on-ramp, and it gets triggered by something like a cut on your skin. Then you've got the intrinsic pathway, another on-ramp that gets going from damage inside a blood vessel. But here's the cool part. It doesn't matter how the trip starts. Both of these roads eventually merge into the common pathway. That's the final stretch of highway that takes us right to our destination, the clot. So that's the natural process, right? But what happens when we introduce anticoagulants? Blood thinners. We're basically putting up roadblocks to slow down the traffic on these highways, on purpose. So the huge question for doctors is, how do we know if we've slowed things down just the right amount and not, too much? We do it with lab tests. And to stick with our little road trip analogy, you can think of these tests as our quality control inspectors. Each inspector has a very specific job, and they're watching a very specific part of the highway. So let's meet our team of inspectors. This right here is your cheat sheet, really. We've got three main tests, PT/INR, APTT, and ACT. And as you can see, each one is linked to different pathways, and they're used to keep an eye on specific drugs. Now let's break down what each one of these inspectors actually does. First up, we've got prothrombin time, or PT, and its partner, the INR. This is our inspector who keeps a really close watch on that extrinsic pathway, the one that gets going from an outside injury. So the PT test is basically timing how long it takes for a clot to form when traffic is flowing down the extrinsic and common pathways. It checks on some specific clotting proteins we call factors. Normally, this whole process should take about 12 to 14 seconds. And this test is the gold standard for monitoring patients on a very common blood thinner called warfarin. Now, you will pretty much always hear PT and INR mentioned in the same breath. So what's the difference? Well, it's actually pretty simple. The PT is the raw number, the actual time in seconds. But because different labs might use slightly different equipment and get slightly different results, the INR was created. It's a standardized calculation. It's a way to make sure a PT result from a lab in one city means the exact same thing as one from a lab halfway across the world. So for a person who isn't on blood thinners, a normal INR is going to be right around 1. But when a patient is taking warfarin to prevent dangerous clots, doctors are actually aiming for a higher number, usually somewhere between 2 and 3. That higher number just shows the medication is working, the blood is thinner, and it's taking longer to clot, which is exactly what we want. All right, let's move on to our next inspector, the activated partial thromboplastin time, or APTT. So if PT/INR is watching that extrinsic road, the APTT is stationed over on the other highway, the intrinsic pathway, the one that kicks in from internal damage. The APTT is also timing how long it takes to form a clot, but it's looking at the intrinsic and common pathways. Its normal time is a little longer, around 30 seconds. This is the main test we use to monitor patients who are getting a different kind of anticoagulant, standard heparin. Now, this is a super important point, so listen up. While an APTT is perfect for standard heparin, it is not the right test for a newer type of drug called low molecular weight heparins. That's a really common point of confusion, and knowing the difference is absolutely critical for getting the treatment right. And finally, we have our specialist inspector, the activated clotting time, or ACT. This is the test they call in for very specific, really high-stake situations. The ACT also looks at that intrinsic pathway, but it's designed to monitor very high doses of heparin. We're talking much longer clotting times here, normally between 90 and 130 seconds. This is the test you'd see being used in a crazy, fast-paced place like an operating room during heart surgery, where huge doses of heparin are used and doctors need results like right now. Phew! Okay, we've met our 3 inspectors, and we've seen which parts of the coagulation highway they each watch. Let's just pull everything back together and look at the big picture one last time to make sure it all sticks. So let's lock in the most important takeaways. If you remember one thing from all this, make it this chart. PT/INR goes with the extrinsic pathway and warfarin. APTT is for the intrinsic pathway and standard heparin. And ACT is our specialist, also for the intrinsic pathway, but only when you're using high-dose heparin. Simple as that. At the end of the day, it all comes down to this. These aren't just numbers on a lab report. They are a direct window into one of the body's most amazing and complex systems. Understanding these values is what lets doctors safely and effectively use medications that have to walk that very fine line between stopping a deadly clot and causing a dangerous bleed. And that leaves us with a pretty cool question to chew on. These tests have been the standard for a long time. But as our medications get even more advanced and our understanding of biology gets deeper, what's next? How are we going to monitor this delicate dance in the future? It's a fascinating thing to think about.